fall in these patients. But if once we have them, then fine. But at this point in time, I think even Healthcare Commission would not be very sympathetic to if an event occurs.
Just one comment. Taking this thing further on, if one even proposes to give a propofol nurse administered and they are capable, I think it's also very important to ensure that you have all the resuscitation, anesthesia trolley, etc., whatever is required by the anesthetist should always be there before we administer such drugs. So resuscitation ki jo equipment hai, I think it should be, if we are going to use advanced or deep sedation, then that should be our responsibility to ensure. And in our practice, our anesthesia department actually helps us out with that, so that we have anesthetists on whenever we need to give deep sedation, whether propofol or if they want to give GA. But also we always have them check our equipment and make sure that we have everything that is necessary for resuscitation of the patient, because once in a while obviously all units get into trouble with the patient going deep, and they need to have whatever is necessary for the safety of the patient. So that's just one word of caution. I'm sure most centers do that, but I thought I'd just share that.
Nadeem, do you want to say something?
I totally agree.
So, Dr. Taqi, thank you for an excellent talk. I would like to just make a couple of comments. I think one of the important things that we all endoscopists need to learn and inculcate in juniors is the phenomenon of the scopesmanship. Now, we know in the sportsmanship that is essentially a fair and generous behavior or treatment towards others, especially in the clinical context. And likewise, if we apply it to our practice, hopefully it will help. I think you very rightly said that it's a team sport. Most anesthetists, especially in our setting, find they're out of their comfort zone when they're down in endoscopy doing these procedures. We have something, I'm sure most centers use it, which obviously surgeons are quite used to, and that is essentially the WHO surgical safety checklist. And that is when you start your list, you make sure you have a huddle with your team members. Everybody knows what you have on your list, what you're intending to do, how long each procedure is going to take. You may have a patient who have a esophageal stricture, you're going to dilate, and then you go on to do ERCP. You may have a patient with another pathology. So you need to ensure your anesthetists know what you have in mind. You may be doing a patient with EUS and ERCP. You may have checked patient Pallimpati classification. You may not happy with their airway. You do not want your anesthetist colleague to put a bigger tube. You may struggle to then get the Pantex or an echo endoscope. So all those things needs to be sort of, you have to think aloud, and that thinking aloud should happen in presence of all the team members. So a concept of scopesmanship, WHO safety list is quite important. Your anesthetist should know what you're going to do. What are the options available if things were to go wrong? Who are you going to call? And especially with regards to the question of whether the patient is going to be supine, prone, or lateral. If the situation arises, would you be happy to change patient on supine to prone or prone to spone? So all those, so that discussion should be, and as I said, that thinking aloud process should be obvious to all team members involved. But thank you very much for an excellent talk.
I couldn't agree more, sir. That's what I emphasized, the value of communication. And I would go a step further, sir. And that's that it's not just thinking aloud, it's active conversation, I would say. That if you have shared your thoughts on this, then the other person has to confirm that they have been communicated, they have been taken, and they have been acknowledged, and there's an agreement with what you're saying. So it has to be an active conversation, I would suggest.
Thank you.
Thank you, Dr. Arshad. We are well past 7 in the evening, and I'm really thankful to you for sparing your time. Sunday is a family day, and you've taken your precious time out of your busy schedule. We're really thankful to you, Pakistan Society of Gastroenterology, Asian Endoscopic Ultrasound Group, and the other educational bodies who are sponsoring this webinar, which is being telecasted live on Facebook as well. And majority of the people have joined on Facebook rather than on Zoom. We have all benefited from you, and we are really thankful to you for coming on this forum. And I'm sure that PSG will love to join hands with you to develop guidelines for guiding on the sedation in endoscopy. And this context, I shall contact with you separately so that we may sit with you, the anesthesia people, to develop guidelines on sedation in endoscopy, not just ERCP, but in endoscopy as a whole, so that we may be able to guide our colleagues in a better way.
Thank you, sir. One last thing, and that is not in my capacity as an anesthesiologist. That's with reference to Pakistan Medical Commission, and that is that as a licensing body, we would be very interested in the society is giving us standards that can against which the individual performances can be measured when a conflict arises or when a problem arises. So we actually look forward to engaging societies like yours, which are vibrant, which are to actually develop standards. Then instead of some authority forming those standards, they should be coming from the societies which truly represent the profession, know what the limitations of the job are, and so that then we can go ahead and get them a stamp of approval from relevant authorities and actually implement them as the guidelines. So that's another thing that we look forward to in collaboration. And thank you very much.